Hi, I'm Mike, and I'm joined today with Cris, and I'm going to have him introduce himself in just a moment. But today we will be going over a case or two in relation to the Dell hand, a case related to the intrinsics of the hand or the small muscles of the hand. So before we get into that, Cris, if you wouldn't mind introducing yourself.
Sure. My name's Cris Bjornson. I'm a student at University of St. Augustine for health science. I'm an OTD student in my last rotation here with Mike, learning a little bit more about hand and upper extremity injuries, and looking forward to being involved.
Okay, so in preparation for this, we looked at an article by Dr. Paul Dell and Cris Sforzo, and that article talked about ulnar nerve dysfunction. So, low ulnar nerve dysfunction. So when you have a low ulnar nerve injury, that can have significant effect to the intrinsics of the hand. So by intrinsics, we're talking about those muscles that originate in the hand and attach to the digits. So they originate in the hand and then attach to the digits, and that would be the intrinsic component, or why they're called intrinsics. As opposed to extrinsics, the extrinsics originate outside of the hand but attach into the digits. So our focus today will be largely on the intrinsic muscles. So we basically have three groups, which probably you learned about in school a little bit.
I think so.
Probably familiar with the lumbrical group,
Yes.
the dorsal interossei,
Yep.
and the palmar interossei.
Yes.
So we will talk about them specifically, but in the context to a specific injury.
Okay.
So we'll begin with a case and then talk about some of the events that would naturally happen to the muscles after the case. Okay, so if an individual has a laceration, I'll use my hand as an example, has a laceration here on their forearm, on the volar aspect, the median nerve, we'll say for our example, is spared,
Okay.
but the ulnar nerve is transected in its entirety. So it's cut, it's lacerated in its entirety, no problem, no tendons are injured, just the nerve. So we'll assume that this individual is close to a great medical facility and they get it repaired.
Okay.
So the nerve is surgically repaired. So sewn back together. About 2 weeks later, you get a referral, comes to the clinic, and they ask you to make a splint and begin therapy. So we'll use that as our stepping stone.
Okay.
A diagnosis of an ulnar nerve laceration on the volar aspect of the forearm. We term these zones different zones. So like a zone 6 extensor tendon area, but no tendon injury, just nerve injury.
Flexor tendon, right?
Flexor tendon. I'm sorry, not extensor tendon. Flexor tendon injury. So no flexor tendon injury, just ulnar nerve.
Okay.
Okay. So in our mind, before the patient comes, we need to think what muscles are going to be affected by the ulnar nerve being cut at this level. It's fair to say that the ulnar nerve's coming out of the brachial plexus, and it's giving off branches to other nerves proximal to our laceration. All of those nerves are still innervating in those muscles and they're spared, right? So we shouldn't have any ulnar nerve dysfunction that's proximal. Our only ulnar nerve dysfunction should be distal. So the question is, well, what will be affected?
Yeah.
So in order to answer that, we need to know what muscles does the ulnar nerve innervate distal to the laceration. Does that make sense?
Yes. Yes.
So the ulnar nerve innervates all the intrinsics. Meaning that it innervates the lumbricals, dorsal interossei, and the palmar interossei. Now it only innervates half of the lumbricals. So it innervates the lumbricals to the ring finger and to the small finger, or lumbrical number 4 and lumbrical number 5. So on our list, Lumbrical number 4, lumbrical number 5 will be affected. The ulnar nerve innervates all of the dorsal interossei, and the ulnar nerve innervates all of the palmar interossei. So both palmar interossei, dorsal interossei completely will be out.
Yep.
And then the lumbricals will be half out. 4 and 5. So median nerve innervates lumbrical number 1 and lumbrical number 2. Does that sound fair?
Yes.
Okay, so if you're the patient, their question for you is like, okay, Cris, what can I expect, right? What's going to happen? And shortly after the laceration, it's not like those muscles atrophy right away. It takes a little bit of time for them to atrophy, right? So we talked about those intrinsic muscles. We didn't yet talk about the hypothenar group and then the thenar group. So in the hypothenar group, we will lose all the muscles in the hypothenar group because they are all innervated by the ulnar nerve. In the thenar group, we will lose a portion of the muscles in the thenar group that are innervated by the ulnar nerve.
A branch of it, correct?
Right.
Right through anastomosis or something.
So the deep branch of the ulnar nerve. So flexor pollicis brevis, half of it, for example, is innervated by the median nerve, half of it is by the ulnar nerve. So we would anticipate the ulnar nerve portion, it's going to waste.
Yeah.
Also, opponens pollicis is median nerve, so it would still be good. But right here,
Our adductor.
adductor pollicis is innervated solely by the ulnar nerve. So when we see this muscle right here, this is a combination of the adductor pollicis and also the first dorsal interossei. They lay on top of one another.
Okay.
Both of them come from the first metacarpal to the second metacarpal, and their muscle bellies in between. So it's the adductor, and then the first dorsal interossei is an abductor. So both innervated by the ulnar nerve. So we have begun to answer the question in our mind, if not had a discussion with the patient. We expect those muscles distal to the laceration to change. They are going to atrophy, right? So what will that look like? It will look like wasting of the first web space, specifically on the dorsal side. It'll be wasting in between each digit. It'll be wasting of the hypothenar and half of the thenar. And there'll be a flattening of the hand. So the hand, instead of having a nice contour, when you lose the hypothenar and the thenar, you get a flattening of the hand.
The loss of hypertrophy.
Yes, loss of hypertrophy. Further, you will get the small finger and then the ring finger to take on this posture. And this would be called the claw hand. And the reason this happens is because the dorsal interossei is affected, palmar interossei is affected, and then the lumbricals are affected. And the lumbricals are responsible for PIP joint extension. But the reason it only exists in the ring and the small is because the median nerve innervates the lumbrical number 1 and lumbrical number 2. So it's just a matter of time, in weeks, in which they will start to develop this type of deformity, and then it will only get worse.
That brings up a good point. So it takes a few weeks for that deformity to actually start to show.
Yes. So, and then that's the pivot part, right? Because if they come to you and their hand looks pretty good, and it's going to look pretty good at 2 weeks because all that atrophy hasn't happened yet, and the claw deformity really hasn't developed yet. It may be starting to develop, but because it was lacerated, you know it's going to get worse before it gets better. So if you see them once and you're like, okay, your hand looks pretty good, I think you're good to discharge. You might discharge that patient home. He or she might, the course of the next month or so, see their hand start to go like this, and you're like, well, I guess that's just the way it's going to happen.
Or they'll get freaked out.
Or they get freaked out, or they might call you in, and then you're like, well, why didn't you tell me that? So you have the ability to anticipate that happening. And you begin to position them before it's a problem to prevent this. So you'll put them in a splint, an ulnar claw splint, that brings the MCP joints into flexion, IP joints into extension in preparation for the deformity that has not yet come but will come.
To prevent joint contracture.
To prevent joint contracture. So if this happens, what happens is you get now a volar plate contracture of the PIP joint of the ring finger and the small finger, and now you've got another problem that never should have existed, but exists because you missed it.
So you want to be on it.
So you want to be on it. So if we talk about nerve regeneration for a moment. So if this happened on January 1st, 2026, the first month after it's repaired is called the latent period. In other words, the nerve fibers are getting their act together. There's really no regeneration. So the first month is a latent period, and then after that first 4 weeks, we start counting 1 inch a month for that nerve to regenerate. So after 4 weeks, after 8 weeks, after 12 weeks, after 16 weeks, that deep branch of the ulnar nerve is right in here. So we are likely 4-5 months away from that nerve reaching the nerve, where the ulnar nerve reaching the branch of the deep ulnar nerve that needs to be innervated to supply juice to those muscles. So these muscles will likely be in an atrophied position, in a deformed position for the next 5 to 6 months.
How long do you think per day are they wearing this splint? Is it like a full-time kind of thing, or is it?
So they can come out of it for exercise, but the whole reason for wearing the splint is to prevent the deformity. So you don't want them spending any time like this.
Okay.
No time like this, because then they'll pattern this deformity. So you want all their time. This is a safe position.
Okay.
I wish I could tell you the number of times where individuals don't get that care early on, and then they come back like this, and then the complications are multiplied. There's a patient that we had. She actually had a both bone forearm fracture, car accident. The both bone forearm fracture, so she fractured the radius and the ulna, and as a consequence of the ulnar being fractured, she had a laceration of the ulnar nerve repaired, and hers was this exact course. So when she came in, we made a splint for her fracture. We also brought her down like this. She got the message it's going to get worse before it's going to get better. Nobody really wants that message, right?
Of course.
But it's the most helpful message you can deliver them, and because it tells you your plan of care. You're like, okay, you're going to wear the splint. Here are your exercises. You're going through some of those things with them. I want to check back with you in 3 or 4 weeks. Make sure the splint's doing well. Your sensation, I want to make sure your hand's not getting burnt, cut, because they'll lose sensibility there as well, right?
Yeah.
And then you stage their visits in relation to the return of the nerve.
That makes sense. Yeah.
And so when the patient gets around 4 or 5 months in our scenario, they're going to start to have these strange tingling feelings in their palm. At the very beginning, you're going to tell them that's going to happen. And so you're forecasting this, and then when it happens, they're like, oh, this is exactly what Cris told me is going to happen. I'm going to have these. This is a great sign. Now, they may hurt, they may be uncomfortable, but that's all good. That means the nerve is regenerating to those areas.
You've told them this, so they're prepared, so they're not as shocked or worried, and
Exactly
save
right.
them an ER visit or something.
Exactly. So that part is crucial. Then what will follow is they'll begin to get some feeling, and then they'll begin to get some motor control, and then it will come back, and then they won't need the splint any longer, and then the other soft tissues around it will be in good shape because you kept them in a protected position. In other words, you gave them an environment for 4 to 6 weeks that was conducive for the nerve to heal and for the other structures to be in their best possible position, for the nerve to heal and for them not to become tight. So when the nerve heals, there's no resistance. There's no other structures that are problematic, and so they're back living life. And you've taken what is a very complicated injury and made it seem rather routine. lengthy, but rather routine. But the only reason it was routine is because you knew your anatomy.
Got ahead. Yeah.
Yeah, you knew what was going to happen. You understood what the approach would be, and then you became really helpful to the therapist. I mean, to the patient. Okay, so let's draw some of that out.
Yeah.
Okay, let's take a different case, still an ulnar nerve case, and we'll take an ulnar nerve case on a police officer. So police officer's right hand, and so this is a true case on a police officer that had an ulnar nerve laceration. It was a low laceration, unable to hold his weapon after the repair for a period of time. So, 4 or 5 months is a long time to be out of work. And for him, his prognosis was not as good as the case that we just shared. So he had some return of ulnar nerve to his digits, but for reasons that may not be entirely clear, the ulnar nerve to the adductor and the ulnar nerve to the first dorsal interossei was not returning.
So preventing him from essentially being able to grasp the end of the tang on the
Yes.
back of the weapon.
Yes.
Pretty helpful there. You kind of need that.
So it's one day in the clinic, and Dr. Dell, who I was working with at the time, as was customary, he would call you into one of the patient treatment rooms. You'd be seeing your patients in the clinic, which was adjacent, and he would call you over and he'd say, Criccio, I need you to come in room B. And you're coming in blind to whatever is in room B. And this happened all the time, and it was a great way of teaching, an unnerving way of teaching and learning, because you never knew what was behind the door. So he invites me in, introduces me to a husband and wife, and the husband happens to be the police officer. And then Dr. Dell asks me what this is right here. And the police officer has a very pronounced mass of tissue here, right? So he says, what is this? And I said, well, this is adductor pollicis, or the first dorsal interossei. That's what is right here. That's what makes up this muscle mass. And he says, no, that's not it. I'm thinking, well, the only thing that is right here is the first dorsal interossei and adductor pollicis. And so it's got to be the first dorsal interossei and adductor pollicis. He's, I know, I told you, that's not it. And the husband and wife are kind of snickering a little bit, and I realize I'm walking into something. I'm walking into some type of snare, some type of trap. I've been set up here for a good learning experience, I'm sure. But so I don't know what to say. He says, clearly, Criccio, this is a testicle. So I said, well, it wasn't on my list.
Sure.
It wasn't on my list. And so this gentleman had a cadaveric testicular implant where his first dorsal interossei and his adductor pollicis would have been, but are not, because they're not getting any innervation from the ulnar nerve. And there's no hope for innervation to that. So there was no hope of return for the first dorsal interossei or the adductor pollicis. So this area would waste in atrophy. So provided with a testicular implant to be a spacer there so that he could hold his weapon.
So how did that spacer act? If we were still not getting innervation to the areas, how did that act to allow him to?
So he would still use his median nerve innervated muscles for motor, and it simply is a static spacer.
So it's just hanging out, allowing him to pretty much use the muscles he does have to be able to grasp. Okay.
Yes. So it's a filler in the space so that the weapon doesn't fall back in there.
Got it.
It also helps to cushion his bone against anything hard, against them.
That makes sense.
So let's take that and let's draw that out a little bit. So we're going to draw the key structures that may be involved. So here is dorsal interossei and adductor pollicis that we're talking about. But before we draw them, we need to draw in some of the other extrinsic structures that may have an influence on this. In other words, we need to know where the dorsal interossei originates and inserts. So we're going to draw a few of the extrinsic structures because the dorsal interossei has insertion into them. All right. So we'll start with a blue marker here, and we're going to draw extensor digitorum communis of the index finger. So extensor digitorum communis inserts just distal to the PIP joint on the dorsal aspect of the proximal segment of P2. And then it goes on proximally and has its muscle mass on the dorsal aspect of the forearm. It happens to trifurcate, or it splits into three right after it crosses the MCP joint. So right after it crosses the MCP joint, let me get a better view here. Right after it crosses the MCP joint, it splits into three. So across the MCP joint, the EDC, which is an extrinsic extensor, splits three ways. So we have a lateral slip, and then a central slip. We also have a few structures that help to centralize the EDC, or what I mean by that is to hold the EDC in alignment over the metacarpal and over the phalanx. So one of those structures are the sagittal bands. We'll see if we can. So in the green right here, the sagittal bands, their job is to hold or centralize the EDC over the dorsal aspect of the MCP joint. They come around and they attach to the volar plate of the MCP joint. But for our purposes in discussion, we just need to draw them here because this is key to the dorsal interossei. Then just distal to them, in pink here, we're going to draw the transverse fibers. So the transverse fibers further hold the EDC in a central position, and they also serve as a sling on the dorsal aspect of the proximal phalanx to pull it into flexion. Okay, and here's where the dorsal interossei is going to come into play. So right now, all we've drawn is a segment of the extrinsic mechanism. Questions, thoughts here so far?
It's pretty involved, right? I mean, look how much we got going on here just to support, a position of the finger.
So in class or in textbook, often you may be familiar with the word extensor hood,
Yes.
extensor mechanism, extensor apparatus, dorsal apparatus. Well, there's really no such structure.
It's multiple structures just put into one.
So what we've drawn here are segments of each of those things. So dorsal apparatus, extensor hood, extensor apparatus, those are all kind of trash bucket terms to capture all these small structures. So when in a textbook, you'll sometimes read that a structure will insert into the dorsal apparatus. Well, it's not really helpful because you don't know where in the dorsal apparatus.
A lot of it.
There's a lot of places it can insert. And so we're now breaking out those components of what comprises the dorsal apparatus. So we're going to now draw dorsal interossei number 1. So dorsal interossei number 1, it's responsible for abduction of the index finger. It's also responsible for IP joint extension and MCP joint flexion, and we're going to explain why. In school, we often learn that the dorsal interossei are responsible for abduction, the palmar interossei for adduction. And that is true, it's just not complete. They're responsible for much more than that. In fact, the dorsal interossei have two bellies. They have a deep belly and a superficial belly. So we're going to first draw the superficial belly of the dorsal interossei. And I'm going to draw the tendon of it first right here. And then I'm going to depict these oblique lines coming to the metacarpals as the insertion of the muscle from metacarpal number 1 to metacarpal number 2. And then the tendon of this inserts into bone. And so I'm going to use this little circle here to indicate that into bone. So dorsal interossei number 1, superficial belly, is bipennate. It arises from the metacarpal shaft of the thumb, or metacarpal number 1, and arises from the shaft of metacarpal number 2, or the index finger. And then it has a bony insertion into the lateral tubercle of the proximal phalanx. So if I draw this on my own hand right here, it has an insertion right there. And that insertion is really important to bone because it's a powerful abductor.
So we're bidirectional at this point, right?
Yes. So this is really important because pinch, right? So it has a bony insertion, so it's powerful. And so if we look at these kind of side by side, bony insertion in here and then insertion into the bone, or originates from the bone of the second metacarpal and then the first metacarpal. And so on my hand, here to here would be the muscle. And so it occupies this kind of mass right here. Now, also there is adductor pollicis, which we're not going to draw in right now. We're just focusing on the dorsal interossei. They overlay one another though. Okay, thoughts, questions there. This is the superficial belly of the dorsal interossei.
Powerful.
All right.
Powerful looking.
Okay, so now let's draw in the deep belly. We're going to use purple to draw in the deep belly. So it will have a tendon that parallels the superficial. We're going to draw purple lines. It has the same origin but different insertion. So we've got red indicating the superficial belly, purple indicating the deep belly. Now, the deep belly does not have a bony insertion. It inserts into soft tissue. It inserts into the pink fibers that we drew earlier of the transverse fibers. So right here in the transverse fibers, the dorsal interossei deep belly inserts. And here, it's the contributor to MCP joint flexion because the transverse fibers are a dorsal sling over the digit. So when this muscle fiber fires, the dorsal interossei fires and it pulls and anchors down and contributes to MCP joint flexion.
Makes sense.
It also has a little continuation right here that we're going to get to momentarily. So, in summary, the superficial belly of the dorsal interossei inserts into bone. It is the powerful abductor. The deep belly of the dorsal interossei has a soft tissue insertion. It inserts into the transverse fibers and then has a little bit of an extension right here that also has a soft tissue insertion that we're going to get to momentarily. Okay? Thoughts, questions to this point?
Complex.
It is complex.
Complex.
Okay, now we're going to flip the hand over. So we've talked about the dorsal interossei so far. Now we're going to turn our attention to the lumbrical. Lumbrical number 1 at least. But before we draw the lumbrical, we have to draw a structure that the lumbrical arises from. So the lumbrical comes off flexor digitorum profundus. So we're going to draw in blue here, flexor digitorum profundus. It has its insertion at the base of the distal phalanx and is responsible for DIP joint flexion and PIP joint flexion and MCP joint flexion. Okay. Well, coming off FDP is the single muscle belly of the lumbrical. It's a worm-like muscle right in this space. And then it has a tendon that's going to come around and it's going to join with that little extension of the deep belly of the dorsal interossei. So the two of those are going to merge together and they're going to form a structure known as the lateral band. And that lateral band will continue on here as blue, and it will join with the lateral slip. So there's a lot right there. So we'll back up. Flexor digitorum profundus, extrinsic flexor. Coming off FDP is lumbrical number 1. Lumbrical number 1 comes off a muscle tendon unit, specifically the tendon aspect. So the lumbrical does not have a bony insertion or a bony origin. It's the only muscle in the body that does not have an origin or insertion into bone. So it arises from a dynamic structure, FDP, and inserts into a dynamic structure, which is part of the extensor apparatus. So it connects the extrinsic flexors to the extrinsic extensors.
Interesting.
Of note, it has more proprioceptive fibers than any other muscle in the body. And it has like a spindle-shaped muscle fiber, and that has much to do with their proprioceptive role, which is a kind of a subject for a different conversation. But suffices to say right now, the lumbrical is a very intelligent muscle, and it acts as a governor, an on-off governor between the intrinsics and the extrinsics. So it has an insert into the little bit of a spit tendon coming off the deep belly of the dorsal interossei. And the two of those together, as they merge, they form the lateral band. The lateral band then joins the lateral slip. The lateral slip is the trifurcating portion of EDC. So this is the complexity.
So this is what allows the precision, I take it.
This is what allows precision. This allows precision. It also is the reason when something happens to this aspect of the hand, why the pathology is so bad. People think, oh, it's just my hand or it's just my finger. Well, it is just your hand, just your finger, until you can no longer use your finger to do whatever it is that you need to do. Yeah. Maybe it's your livelihood. Maybe you're a dentist. Maybe you're a professional quarterback. Maybe you're a potter and you can't do those things that you want to do because these structures have been changed somehow. Or because the nerve that supplies juice to the muscles here has been severed in the case of our example here. Or you have a traumatic accident and all of this becomes really edematous and full of swelling, and now these structures are kind of stuck in cement. So in our case, when we have an ulnar nerve injury, both the deep belly and the superficial belly, those are wasted, right? Adductor So we lose the integrity of muscle in this space. We don't, however, lose the function of lumbrical number 1 because it's innervated by the median nerve. So we still have function of the PIP joint.
Just lost strength, essentially.
You have less strength. You have less strength. So we mentioned that the dorsal interossei in school, we learned that they abduct. They do. The superficial belly abducts. But what we didn't learn in school, it also has a deep belly, and that deep belly contributes to MCP joint flexion and then IP joint extension. And it does that by virtue of its insertion into the transverse bands that pull it down into flexion, and then also its little extension right here that joins with the lumbrical to form the lateral band, and then that contributes to IP joint extension. The other kind of fallacy when you look at a textbook, and I was guilty of this for probably a good part of my career, definitely through school, is that you look at a schematic and you think, okay, there's the intrinsics, and you see it from whatever vantage point you see it. And the assumption is that those intrinsics that you see in that two-dimensional drawing is the same for every finger. And it's the same on the ulnar side and the radial side of every finger, and it's not true. It's different. So as we get more skilled in understanding anatomy, one of my favorite things to do is to look at a schematic and determine what finger is it by the anatomy that's drawn two-dimensionally. And is it the radial side or is it the ulnar side?
Is this newer information, this whole structure that we kind of went through today, or is this just kept out of the textbook on purpose, say?
Great question. It is not new information. It's the anatomy that's been there. We have great hand surgeons that teach that. I think the fact of the matter is you can get away with practicing without knowing this. And you get in the weeds very quickly. So if you're writing a textbook, so I don't think this is it's not a slight to any textbook, because I think you get into the weeds, and then if you're writing a textbook, you have to decide what is the most important information to put in the space that you have to do it.
Yeah.
And so they can encapsulate much of what we've drawn here in a phrase: extensor apparatus, dorsal hood, and that becomes very convenient. And I think the convenience then becomes part of the curriculum, and then we lose this part of it. But this is the difference maker. So if you understand the anatomy, it changes your approach to all different diagnoses of the hand, elbow, and shoulder, because when you have an edematous hand on an elbow injury, you realize how important the hand is for the elbow functioning, and then you realize if the swelling sits in here, you know all these small structures are going to turn to cement, and you've got a real problem. So you have to determine, okay, how can I move these structures? What's the safe way to move them? And if you understand the anatomy, you understand how they should move.
Now, I guess another question that someone would raise to that is, well, there's only so many motions that we know these digits can do, right? So if you didn't know this information, you still know, okay, we can get into flexion here at this degree. Could you still plan an effective plan of treatment without knowing that anatomy, or do you think that you could run into some areas where you might actually make it worse?
So I think great question. I think you get lucky.
Get lucky.
You get lucky, and I think I've gotten lucky earlier in my career where you're, like tendon glides would be a great example. Tendon glides are focusing largely on the extrinsic structures, minimally on the intrinsic structures. And so I've missed probably a lot of things in helping people in different ways. We'll use the phrase that the diagnosis sees you, but you don't see it. So the more that you know the anatomy, the more that you see it. In other words, you see the dysfunction because you understand the anatomy. So back to your question, I think you can skate by. I think a lot of people do skate by, but I think you get lucky in some cases, and then some other cases, the patient bears the consequences of you not knowing.
Like they didn't get completely healed,
yes,
or something was missing.
So if we use the case of the opening patient that we talked about with the ulnar nerve injury, what can and is easily done is the therapist assesses the patient. They appear pretty normal after a nerve injury, and you're like, okay, you're doing great. But because they don't understand the anatomy and what's going to happen after the nerve injury, they're not forecasting what's going to happen in a couple weeks, so they're not even seeing it.
They're just looking at what's in front of them. Yeah.
And when the patient comes back, right, in 4 weeks because they're upset and then now they're stiff, you're like, oh, shoot. A lot of times you're not even understanding what happened in that 4 weeks, right?
Yeah.
Surely it's the patient's fault. They did something, right? Or oh my gosh, it got worse. And you're shaking your head, why is it going to get worse? But you have no idea why it got worse, nor do you have any idea if it's ever going to get any better.
You're lost.
You're lost.
Yeah.
And you may get lucky in some cases, but that would be a case where it's going to expose you. Maybe the patient doesn't come back and you learn from your mistake. So anatomy helps you to understand what's in front of you and also what might be in front of you in the future. So you don't know what you don't know sometimes.
Yep.
So I feel pretty fortunate that fairly early on in my career, Dr. Dell is calling me into patient rooms. And he's teaching me more than just testicular implants, right?
Good.
So he's using that as a story, which is kind of fun and it's novel and it's it can be comedic, but if you step outside of it, what he's doing is he's cementing in that knowledge, right? Hey, Critcho, do you understand this? And he's putting you on the spot,
Yeah.
And you're like, okay, I guess I don't understand it. Right? I better go back and I better understand it a little bit better. And then the more you explain it to your patients, the more that you're going to understand it. And then the more that you vocalize it, the more that you're learning it, and it becomes, okay, I know that, no, I don't know it. So if you can draw it, then you know it. I was at an ASHT conference, which is the American Society of Hand Therapy conference, one year, and there's a surgeon on the big screen, and he's going over a surgical procedure, and he pauses and he teaches in an academic institution, and he was talking about his fellow involvement, and he says before the fellow can begin the approach, I have the fellow on the table draw out the approach, and if they can't draw out the approach, they're not doing the approach. So on the surgeon side, the need to know the anatomy is finite and it's requisite because you're in there doing surgery. On the therapy side, you can get away without knowing. You shouldn't be able to get away without knowing, but you can.
I think that falls suit in terms of structure size too, right?
Sure.
The bigger the structure, the easier it is to get away with things.
Yes. And the smaller the structure, the more the nuance. Mm-hmm. So this just encapsulates, one small example. So we'll conclude by drawing in on the index finger one final structure, and that would be the palmar interossei. And it's fairly straightforward. So the palmar interossei is responsible for adduction, innervated by the ulnar nerve. It comes off the volar aspect. Okay. Oops. We're losing our red. I better go purple. So it comes off the volar aspect and then comes in on the second web space and joins with the lateral band without getting too complicated right now. Essentially, it comes through the first web space and it adducts the finger. It has a street name change as soon as the tendon of the palmar interossei crosses the MCP joint. It has a street name change and we call it the lateral band. And it joins with the lateral slip just as the dorsal interossei joins with the lateral slip. So the lateral slip on either side of the digit is the EDC. So it's the extensor mechanism, the extrinsic extensor mechanism, and it joins with the lateral band on the ulnar side and joins with the lateral band on the on the radial side and then the ulnar side.
So these lateral bands essentially assist with extension, flexion, and abduction and adduction.
So mostly extension. So lateral bands, they contribute to extension. The FDP and FDS, they're taking care of the flexion. So lateral bands responsible for PIP joint extension and DIP joint extension. Okay. Yeah. All right, so there's a lot there. So we'll kind of continue this discussion kind of case by case, and then kind of practice drawing it out.
Sounds good.
Alrighty, any concluding thoughts?
No, I guess know your anatomy. If you don't know it, go back and look at it and make sure you know it.
Right. So it becomes fun, and I should go back into just real quickly on the case of the girl with the both bone forearm fracture. She had an anomaly. So when her injury got worse, her small finger and her ring finger went into this position, as they should. We would expect the middle finger, or the index finger and the middle finger, to be normal because the lumbrical is supplied by the median nerve. But her index finger took on the same position as the ring and the small. So we scratched our heads on that. At first, the trauma surgeon thought that she had a central slip, EDC rupture. She did not. She get actively extended. What happened was that she had an anatomical variation such that her lumbrical number 1 was innervated by the ulnar nerve. Lumbrical number 2 was innervated by the median nerve.
Wow.
So we had to treat her index finger just as we treated these two. Now, at the time, we were just surmising that based on what was normal anatomy and then what was kind of our best educated guess. So we treated it just like these two, and then we knew that was a problem when she started having sensations to her index finger, and it returned at the exact same time her ring finger and small finger did, meaning that she had an anomaly. She had an anatomical variation. So it taught us a really great lesson that if you know your normal anatomy, you can do a better job of ferreting out what is a variation of that normal anatomy. If you don't know your normal anatomy,
Keep scratching your head.
Keep scratching your head. All right, so I think that concludes this segment on the Dell hand case number 1.